Okay,
All
I
right,
believe
looks
we're
like you're
good to
going again.
go. Thank you so much, Nina.
Yeah,
And
of
thank
course.
you, James. It's all yours.
Well, thank you very much. And thank you very much for the invitation to come and talk to you variously this morning, this afternoon. I don't know if it's and evening as well. I'm going to talk about intervention complexity and systematic reviews. And this is the talk, more or less, that I gave at the Cochrane Methods Symposium a few weeks ago. I was told that that would be all right and I wouldn't be sending you to sleep again if you've heard me before. So hopefully this will be new to most of you. I just thought before I get into complexity, I should probably just let you know where I'm coming from, where my background is. So that's my office. I've literally not seen it now for over a year, but I believe it's still there. I've worked there at the EPPI-Centre for many years now. And it's part of the University College London, and it's a specialist centre for evidence synthesis methods, development and implementation. I lead the systematic reviews facility for the Department of Health and have done for a number of years, where we undertake systematic reviews to inform policy, and we work with Public Health England and NHS England and a number of other organisations. Basically, our job is to help mediate research into policy and decision making. And what we found when we were working with policymakers is they often ask us to address questions that go beyond effectiveness. So questions about process, questions about acceptability, questions around differential effectiveness, whether something works better with one group or another and that kind of thing. I've also been interested in making our processes more efficient. I've seen how long it takes us to do reviews and it's too long. And we spend a lot of time looking for research and classifying research actually that we're not interested in for the reviews. So I've done quite a lot of work in recent years around using new technologies to try and make the process more efficient. I should declare my Cochrane roles. So I'm a review author on some Cochrane reviews. I'm also one of the co-conveners on QMIG, the Cochrane Qualitative and Implementation Methods Group. I'm a senior scientific editor with Julian Higgins on the Cochrane Handbook. And I co-led Project Transform with Julian Elliott a few years ago, which was around support with those new information technologies. The work that I'm presenting here is not just my own thinking. Many, many people beyond the group mentioned here have contributed to this type of thinking. So I should say up front that you know, this is definitely standing on the shoulders of giants rather than just what I've been thinking over the last few years. So what I'm going to be thinking about, mapping out where we're going, is some of the main issues relating to complexity and intervention complexity and the thinking that surrounds them. There are different ways of thinking about complexity in terms of being simple, complicated, and complex, which we'll cover, and also complex systems, complex adaptive systems. So put all of those different concepts together there. I'm going to illustrate somewhat some trepidation with examples of face coverings during the pandemic. So just in terms of orientating ourselves a little bit, I think it's important to sort of recognize and acknowledge that when we're doing research, when we're reading research, when we're interpreting research, we do so with pre-existing assumptions. It's not as though we have a blank piece of paper either in our minds or out there in the world. Some of these assumptions are explicit, so we make very clear our rationale for doing something and thinking something, and sometimes they're not, they're implicit. But one of the things which I found particularly sort of important in terms of thinking about complexity is actually we can choose which set of assumptions to use at times. And sometimes it's really useful to be able to do this depending on actually on which gives us the most utility in a particular situation, what gives us most analytical purchase. Assumptions can provide us with the tools that we need to analyze phenomena of interest, and also really importantly to communicate with other people about it. Sometimes you just need to reframe a message in the type of language and the type of scope which the people listening to will sort of receive it in order to sort of make that connection between what's the research is saying and actually how it can be used. I'm also going to asserts that our assumptions underpin what I've called epistemic security. And I've sort of approached this with some trepidation, and we're not going to get into a big long lecture here on causal inference, but it's quite important to think about our stance and our pre-existing assumptions about what we're expecting when we're making causal claims. There are lots and lots of pieces of literature on causality, so I'm not going to sort of revisit them all now, but roughly speaking, there are a couple of accounts which are quite important to the way that we do systematic reviews. They're sort of like the counterfactual and probabilistic accounts that we're very used to seeing in systematic reviews of effectiveness, where basically we're asking the question, what would happen if we did this, or what would happen if we hadn't done this? And obviously randomized trials are brilliant for that because they actually give us one of the best estimates that we can get in terms of counterfactual inference. So they give us a real insight into what would have happened if we had or hadn't done a particular taken a particular course of action. Those are often contrasted with regularity and mechanistic accounts of causality. And here what we're thinking about is, rather than saying, well, what would happen if we'd done something or what we hadn't done something, but actually we understand the properties of a phenomenon well enough to be able to predict what it's going to do under particular circumstances. That's a very different way of thinking about prediction and causality. It's around understanding its properties so well that we're able then to say with some degree of certainty, this is what's going to happen if I see this particular situation. And the challenge we've got when we're thinking about causality, when we're thinking about making predictions, is that we need to think about how we can inform real-world decisions with the evidence that we bring to bear. Sometimes we're able to draw completely on counterfactual types of evidence. Sometimes it's more difficult than that, and that's really one of the sort of the main themes underlying this talk. So simple causal models, sometimes it's really helpful, and this works fantastically well when it does work. Thinking in simple linear terms, like hitting the puck, we've got an action which causes an outcome, which causes that we see the effect as a cause and as an effect. And because of the type of action we are observing, we can be reasonably certain that the effect is due to that cause. We use counterfactual reasoning sometimes to help us, or counterfactual evidence to help us with that. But basically what we're wanting to observe, or what we're wanting to be able to assert, is that this cause resulted in this effect. And then when we can do that, and when we're thinking about using that type of evidence in a systematic review, and other types of evidence too, as research, this isn't just evidence synthesis, but the questions then are around, well, how often does this cause have that effect of interest? How large is that effect? And how consistent? How often do we see that? And those are core questions which a lot of Cochrane reviews answer. They answer very well. So if we're thinking about a more practical example, one mechanism that we're all been quite familiar with, I'm sure, the last few months, are face masks, face coverings. On the face of it, a fairly simple mechanism. It's a barrier, prevents or reduces particles from entering or leaving the mouth and the nose. Not rocket science. And some studies, and we've been maintaining a map of the research, so we've seen these, address a question of efficacy there. They do indeed look to see whether these face coverings do prevent particles going in both directions, and they can. So is that the end of the debate then? Masks work, or is there more to it than that? This is UCL. I believe this is what it looks like at the moment on the right. We've got an intervention here. Face covering should be worn at all times when moving around the building. And on the left, we've got advice from CDC about strategies and outcomes and impacts from wearing face coverings. On the right, also in the UCL picture, we've got another intervention, which is around keeping your distance. So let's contrast that with what we saw in the previous slide of a simple intervention looking at whether a face covering can reduce particles moving from the nose and the mouth. In this case, what we don't have actually is a barrier at all. what we have is a sign on the wall saying that you should be wearing your face mask. What we also have is another picture which says keep your distance. So we've got two components of this intervention, and actually there would be multiple other components about emails and all sorts of things around campus trying to reduce infection rates. Likewise, on the left with the CDC strategy, that's not just around wearing face coverings, it's part of a strategy as part of other parts of an intervention. And so things start to get a little bit more complicated when you move from an intervention, no matter how simple the intervention might be, into implementation of something, especially with the people that I often work with, which is at the sort of national policy level. So this linear model of causation starts to break down, especially when there are these long causal pathways between intervention and outcome. So we've got that face covering, but actually the intervention isn't actually the face covering. It's around persuading people to use the face covering. And obviously there'll be all sorts of factors at play there, including whether or not people wear the face coverings properly. The other thing is that because social contexts are so different, that even if we've got decent evaluations, which on the whole we don't of this intervention, intervention replication is very rare, stroke almost impossible. So what we end up with at the evidence synthesis level is not a nice sort of neat lining up of intervention and with the same intervention with the same population. What we have are examples of interventions with different populations which differ ever so slightly. And with that picture of the UCL example, what they also differ in is the components of the intervention, one of which might be the one that we're interested in, but then they get combined in different ways with other intervention components. And the systematic review jargon for that is we have lots of heterogeneity, both in terms of the clinical heterogeneity, as in the context, the population and the intervention, but also often in the effects that we observe as well. So when we're dealing with something which has moved possibly from a simple intervention into a more complex environment, the focus of what we're looking at starts to change, and our questions themselves start to change. We are not able in this particular sort of situation to start to say, well, how large was the effect, how consistent was it, how often we observe it, etc. Because there's actually no single effect in different studies. What we have are these examples of how something has or hasn't worked in a particular context. And so the questions that policymakers ask, to be fair, start to focus on explanation and understanding as to why we saw something happen there, whereas we saw something different happen over here. And what they're really interested in knowing is what's driving those differences in observed outcomes. So you'll have no doubt have seen various sorts of permutations of the phrase what works for whom in what circumstances, but that's actually not a bad summary of the types of questions that we get asked by policymakers. They're also interested in the relative importance of synergy between the different components of multi-component interventions. So those signs on the UCL wall, does it matter that we have the social distancing, the keep your distance, as well as the face covering? But then also, when we're thinking about picking apart those multiple component interventions, which of those components is more important? Do they have some kind of additive effect? Does one sort of overplay the effect on the other, so you actually don't need one of them if you've got the other? We don't know, certainly for that particular intervention, but it's one of the questions that is asked when you're thinking about, okay, so I've seen a particular example of an intervention which has got multiple components in one situation. Should I use them all? Should I try and replicate the whole thing somewhere else? Or should I be taking particular parts of that? And if there are particular parts, which parts should I be taking? And there are questions, of course, about feasibility, acceptability of using interventions from one context and putting them in another. And that then starts to bring us on to dynamics of the context, the wider system within which we're introducing an intervention. So you probably have no doubt seen complexity and complex interventions talked about. And to begin with, people were thinking about complexity in terms of multiple component interventions, but we quickly realized that that didn't really capture the real complexity of this of the context in which interventions are introduced. true complexity, as people started to describe it, are situations where you've got these non-linear effects. We've got phase changes, we've got feedback loops, and where actually the causal pathways are less well understood. So, we think back to that little intervention at the beginning, the wearing of the barrier, the face covering, moving through to the introduction of signs on the wall. The pathway between someone wearing a mask and infection rates in the UCL campus much longer than simply observing whether droplets are going in or out of through a particular barrier. There's many possible pathways for effectiveness. Those pathways are less well understood. Is it the fact that you see other people wearing masks that makes you wear yours rather than having a sign on the wall? Lots of different reasons why the intervention may or may not work. And so interventions inherently become less predictable. Case in point here: reject bad science, bring back the smile, save the human face, democracy is dead, etc. All of these campaigns on one side rejecting the wearing of face coverings against Dr. Ellie Mully's Twitter profile picture I've got here, which is great. Mask protects you, your mask protects me. So we've moved from a sort of a relatively scientific question as to whether or not infection rates can be reduced through wearing a face covering into the social and now into the political domain. But completely key to understanding whether or not a particular intervention should be introduced into a social system, and the potentially unforeseen repercussions that can arise from doing so. So that really sort of demonstrates, and I think bring home quite nicely, the challenge of introducing interventions into complex adaptive systems where you've got long pathways between the intervention and the potential outcomes that you're interested in. And actually, what's absolutely critical is the interaction between the introduction of the intervention and its system, and that actually is what is driving what we think of as outcomes. And it's also useful to think of outcomes as being properties of the system itself. They're produced by a system, by lots and lots of different interacting influences, rather than just being a linear, we've hit the puck, therefore we see the outcome here. One useful insight was seeing interventions as perturbations within a system. There's lots and lots of other things going on in people's lives. An intervention could be one thing, one drop that goes in, and it has ripples that go out, but the system itself will actually generate the outcome. And what the system often tries to do, or systems try and do, is remain stable. So they respond in ways which may be unforeseen. So for example, the political dimension of wearing face coverings, which was really quite a surprise, I'm sure, to many. And it's really important to note that it doesn't change what is actually happening. The actual action of wearing a face covering and whether or not it can prevent a virus moving backwards and forwards, that's not changed by the system itself. What's changed is our understanding of what it means to introduce an intervention like that, and what is likely to affect or impact on its ultimate outcomes. We've changed our questions, so our answers are likely to change as well, the types of answers that we change. We don't get overall precise estimates of the effect of an intervention. Sometimes what we're looking for is explanations as to why we've seen a particular effect in a particular situation. What policymakers are really interested in are variations in effect, where especially in relation to inequalities, for example. One of the key policy drivers at the moment is whether or not something may increase or decrease inequalities. Really important question. So we're interested in variation in effect. But also we're interested in different types of evidence. We can't just randomize people to different conditions. We can't randomize people to different socioeconomic status, for example. There are different types of evidence that we might want to draw on in order to answer some of these questions about variations in interventions effects and about why something may happen in a given situation. And these offer some challenges to our traditional epistemic security that I noted at the beginning around counterfactual accounts of causation. So if we don't have a counterfactual, if what we're starting to need to do is to look at the other types of causal inference, those offer us some challenges, and they make it more difficult for us to be able to sort of say, well, we know where we are with this, we've got a randomized trial, this is the effect, this is how often we see it, etc. The last piece of change, you'll be glad to know, is around the knowledge of evidence use. When we've got a counterfactual account, where we've got a relatively simple cause to effect, we can see situations where an instrumental use of knowledge is fine, where it actually works really well, where we can say, oh, okay, so that's the intervention I need in this particular context, and that's the likely outcome that I'm going to see there. We move towards what I put here as enlightenment models. People have called it different things over time, but where what we're thinking about is understanding and sort of understanding of the context within which interventions are introduced, and understanding of the issues raised, rather than being able to take a piece of evidence and say, right, that gives me my answer. More the enlightenment model is around, this helps me think about and think through what the issues are that I should consider around introducing a particular intervention. In practice, it's important to bear in mind that thinking about complexity and complex interventions like this are heuristic devices, and the whole point of them is they should help. You can end up modeling an entire system if you're not careful. And so it's really important to think about actually which factors are most important, where are the boundaries around the system. People often draw logic models and the like in order to sort of articulate the key concepts and the key characteristics of a particular context that they need to take account of. Different types of research are required, which I've alluded to a little bit before. So we mixed methods reviews, evidence syntheses, which take on a multiple different types of evidence, enable us to see more of a system than a sort of like a single type of evidence can do. Bearing in mind all the time that what we're wanting to do is make things as simple as possible, not simpler. So it's very possible to be completely lost in complexity and think everything's too complex, we don't really know anything about anything. Obviously, we do know something about some things, but actually what we mustn't do is sort of overcomplicate things, keep them simple where we can. I've said that evidence synthesis is a good strategy for helping. Individual studies, by definition, look at a particular research question. If you're thinking about that big complex system of introducing face masks in a social situation, clearly there's lots of types of angles that you might want to cover when you're thinking about doing that, not just about whether or not the face covering can do what it's supposed to do, but whether or not people can wear them in a way which is compliant with actually them doing a good job. Wearing them around the neck doesn't do the trick, for example, but also whether or not people will wear them, and all of the social and the political angles which are relevant here. So you may want studies around efficacy of these face coverings, but you also want studies around people's attitudes and beliefs. And obviously we've got one where sort of a more trials and more quantitative research is useful, and others where qualitative. So traditionally, our systematic reviews have been very good at addressing those initial questions about size and consistency of effect. And we've been less good about how and why we see variations in effect. We very rarely get into questions around systems perspectives. And there are good reasons for that, because when we're looking at questions of cause in effect and the consistency and the size of that, we can use randomized trials, and we can do a meta-analysis, and we can say, okay, so here's the size of our effect and here's how consistent we are. Great. Things get less comfortable for us as soon as we start to move into questions of how and why. We may do subgroup analyses, and of course, as soon as we start doing that, we realize we're not protected in terms of our counterfactual claims with randomized evidence. What we're looking now is at observational. And so all of the different biases and limitations arising from use of observational evidence then come to the fore. And so it's an uncomfortable place for many systematic reviewers to be. But I think this question is absolutely critical. And it's not one that we can get away from. The more that we stick to our security, our epistemic security, sticking to answering questions for which we can give those answers, the less actually we're giving answers to decision makers that enable them to grapple with that complexity that I've been outlining. And so the key methodological challenge for us is around how we can generate methodologically rigorous evidence synthesis, but still being able to answer and address some of those legitimate real-world questions. So that's the question I thought I'd leave you with. I don't have answers on all of that, but I think there are examples of where people have been able to sort of solve some of that conundrum. In summary, sometimes this linear causal model does what we need and it does it well. So let's not minimize that and the contribution it makes. But sometimes a different perspective helps, especially when we're starting to think about those complex systems within which we're introducing interventions. Different types of research can contribute there. And I really do think that evidence synthesis can play a key role, but it's a real challenge to us in terms of thinking about how to generate methodologically rigorous evidence, which we are happy to sort of put our names to. And I'll end by saying, it's possible to get too complex, so let's not. Yeah, thank you very much.
Thank you very much, Dr. Thomas, for bringing us to think about complex interventions and all of the technicalities that arise with thinking about them. Your lecture reminded me of a podcast I was listening to this morning on dermosphere, which I think is the best podcast for dermatologists to listen to. Michelle Tarbox and Luke Johnson go through the literature and really help digest it. And they had an award for the most surprising story in the literature last year. And it went to Dr. Steve Feldman for talking about, in terms of medication compliance, how to get people to use their medication and fear of using topical steroids. Their bottom line was that stories were better than data. So there was a study that looked at the effect of giving more data on people's use of steroids for skin disease and the effect of telling them a story. And stories won, hands down, and that giving more data to the patients did not necessarily decrease their fear. So I think that's kind of an example of a complex intervention. Our minds are perhaps geared more towards the complex intervention of hearing a story than hearing more data on something that might do us good, and that might extend into the political as well. But I want to open up the questions. If anybody would like to ask Dr. Thomas a question, and also, James, I apologize that we didn't turn off the doorbell for the Zoom room during your talk. You did admirably well.
I wondered what that was.
And we will turn it off as soon as we take a break and stop the recording for a minute before Dr. Parker starts. But do we have any questions for Dr. Thomas? And you can feel free to put them in the chat as well.
Can I ask a quick question, Rob?
Sure, Bob.
Thanks, James, for a very thought-provoking kickoff session. That's really, really terrific, and I think it probably made many of us reflect on the value of what we do. I mean, I just one sort of query, really. I guess some of what you're arguing for is the value of implementation science, and I think. How much does that need to be reinvented for every intervention? Or can we make reasonable suppositions about our ability to identify relevant barriers and sources of variation in effective interventions versus doing a whole bunch of implementation science around every sort of new bit of the piece that we're thinking of adding in there?
I think that's a good question. Yeah. Yeah, because on one level, the description of complex adaptive systems and the like would suggest that every situation is unique, and that's one of the arguments that's often put forward in the literature, that if this is I'm unique, this is unique, everything is unique, therefore you can't take learning from here and apply it to me because I'm this is too unique and different. But having done a number of these unique examinations, there are just recurring themes and recurring sort of mechanisms of action which just are just there all the time. And some of the time with we ask the same questions almost as though we've forgotten the answer that we got last time we asked exactly that same question. So I mean, and a lot of it will stem in terms of equity and health inequalities. We're asking exactly the same questions that were asked 20 years ago, and there should be no surprise to anyone around the sort of like the social dimensions of the effects of COVID-19. I don't know why even it's a question. It's a legitimate question of inquiry and etc. But it shouldn't be a surprise anymore. So I think that yes, people over-claim about the unique contexts in which something might be introduced and fail to take account of the fact that actually we've asked very similar questions before. What we're not able to do, it seems, for some reason, is to learn from what we've seen in the past.
Thank you. Hal's got a question, I think.
May I speak, Bob? Okay, I'll make a start. James, roedd hwnna'n ardderchog. So,
my family is from Wales, but I'm afraid my Welsh is very bad.
Very, very good, very good. No, I've been interested in complex adaptive systems, complexity in medicine for a long time, so it's lovely to hear it being discussed here. So and I think your example of wearing face masks, whether wearing a mask then alters your behavior in terms of making you more confident, the same with vaccination. It really is, perturbation of a very complex adaptive system where there may be buffering and sometimes surprising effects from small interventions, or the sandpile effect when you get 2 or 3 things. So you described the issues of the non-linearity and the thinking about it. But what I wanted to ask you, James, was how do you do it? If you're going to inform the policy research program, is it a mixture of a logic model, maybe a realist synthesis, maybe a compilation of process evaluations? What do you do to put it up? Because I live in the health technology assessment world, but for policy research, what is the sort of product, and what are the components of the way you try and solve these problems for policymakers and decision makers? Thank you.
Yeah, no, it's a kind of a luxury program in a way, because you've got that that immediate connection with the policymakers, so you can talk about these things in detail, and sometimes you've got the time to engage over an extended period. Sometimes there are, for political reasons, often there are sort of like rapid evidence assessments and rapid reviews needed. Where they just look like what you'd expect, rapids and scoping reviews and that kind of thing. But we've always got sort of longer term pieces of work underway as well. And one nice example was some work we did with Keith Ridge and Hilary Cass and some people looking at pediatric medication error, which is a difficult question, and they were just sort of tasked with solving it. From this panel a few years ago, and so they said, well, we got to look at the evidence first, and so we literally did really quite a nice sort of story in terms of, they said, well, okay, so what's the extent of the what's the extent of the problem? So we started with evidence synthesis or epidemiological literature and looking at literally where are errors most frequently seen, what type of errors are we seeing, and that kind of thing, just to understand what the problem was. We then went to the effectiveness literature in terms of, well, what are people doing about some of these particular areas of medication error. And then once we'd looked at that, and there were some sort of approaches around electronic prescribing systems and things that they wanted to look at in more detail, we then went on and looked at the process, in the process evaluation literature. So, and we were looking then at implementation issues, because, for that area especially, implementation was absolutely key. And you got the implementation wrong, and you do more harm than good. Even with the same system will do more harm. So it was quite nice in that they worked with us in that they were saying, okay, so this is where the question is at the moment, extent of problem, what do we do about it? But then getting into actually, okay, so even if that's a solution, how do we implement it? So that took a year, that piece of work though. So
yeah, thanks a lot. So a real dialogue then between the decision makers and the evidence producers.
So your question just broke up just.
So that's helpful, James. It's much more of an interactive dialogue between the decision makers and the team producing the evidence to answer that. That's quite a helpful perspective. Thank you.
Yeah, I just
go ahead, James.
So I was just adding to that one of our sort of principles is that we are at arm's length from the decision makers. So we interact closely to understand exactly how the evidence will inform the decision, but we're really clear that we're the ones who say what the evidence says. And it's good from both sides that we have that understanding. So, and they don't get to inform or spin the findings of what we come up with. We just say, okay. But what we do want to do is make sure that we're going to speak to that particular context, the decision-making context.
Thank you very much, James, for this excellent keynote opening lecture of our conference. You've started us out on a great footing. I'm going to now stop the recording and hopefully turn off